join me in the Pledge of Allegiance?
Yes.
I
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
I don't have a gavel. They can give me one.
No.
Oh, okay. Public comment, seeing no public, we'll move on. The consent agenda, has everybody had a chance to look over the minutes? Both of July 16th.
They were late, you had to be quick.
And July 13th. You just have to be able to read, Gerald, that's all.
I want to record it, like read a book. Can you do that, Jen?
Or read a book. I thought maybe we weren't gonna have them this time, Jen.
Yeah.
I just didn't drag them in, and I caught it today.
Okay. I enjoyed the thank you letters.
Yes.
It was very nice.
Yeah.
Yeah.
There are more and more notes on Facebook also.
I try to print those out as I see them and get them into.
Facebook, where do you access them on Facebook? Lake Health District? The Lake District Health?
We have a
Oh,
website.
really?
Or-
think
Or
we have any
a
blogs.
Facebook page.
It's on our,
Facebook, I mean.
when you're
Be their
on it, you
friend.
have to look for the one that says visitor posts, and that's where they'll post them instead of our page. It shows up kind of on a sidebar as visitor
Oh,
posts.
and that's nice.
Mm-hmm.
Okay.
I thought Barb Harlan's was very well done,
Right.
complimentary,
Yes.
but a little bit
There are a
of
couple of suggestions.
suggestions that I thought were appropriate. Yeah, that's good.
Okay.
So you want us to approve those? I'd so move.
I'll
Okay.
second.
And moved and seconded to approve the consent agenda as presented. All in favor?
Aye.
Opposed? Hearing none, passes unanimously. Nursing, employee health, Mesa.
So I've been working with Teresa and Charlie. We met last Friday about 2 new policies that we're getting ready to roll out. And kind of wanted to make you guys aware because it will affect majority of the employees, if not all of the employees at some point in time. The first one is the influenza vaccination and the masking policy. We have basically adapted St. Charles policy that they rolled out last year. It doesn't mandate the flu shot, but it does mandate that our employees wear masks if they do not get the flu shot by December 1st. The flu season runs October 1st through April 30th, whatever. But we would, so I usually start the immunizations middle to end of October and run them all the way through November, even into December for employees to get. They're free of charge. I try to make it a wide range of days and hours, morning, early morning from like 6 to 1 and even like from noon to like 6 or 7 at night so I can cover those night shifts. We are going to be making a few improvements I think will help with our compliance rate because right now we're at 60%. And in 2 to 3 years, the CDC and the state public health want everybody at 90 to 100% compliance rate, and that's going to be really hard if we're still at 60%. So one of the things that Teresa Decker and I are doing is we're not ordering multi-dose vials this year. We're ordering single-dose vials, so they'll come that way. A lot of people won't get the shot because they fear for infection using the multi-dose vials, even though we use the alcohol wipes in between, puncturing the vial. So we'll do that. The other thing is we're also going to make them available in the Omnicell, which is the medication distribution station and the nurses station, so that night shift can give them, to each other, the nurses, whatever, or like if a housekeeper or somebody that only works weekends comes in, that they can easily pull it out of the Omnicell, sign the consent form, and give it to the employee. I think that both of those will help. Those are both St. Charles suggestions that they do that has really helped increase their numbers, so I do believe that that will help our numbers as well. St. Charles also has special ordered stickers go on the name tag so you can tell if the employees have had the flu shots or not, and they can't be duplicated, so I will have to order them from a certain company. And last year what they used were like just little syringes, and they were red or green. And when I went up to St. Charles and worked with the infection control nurses up there, I noticed it immediately on all the name tags of the patients or the employees. It's very visible, and you can tell right away if they've had their flu shot or not. So I think it's going to be a challenge, and I think I will get some resistance and pushback, but I think overall, for the safety of our patients and our community, this is kind of where everybody is moving forward. And I've spoken with several hospitals that have way higher rates than us, such as Burns, John Day, and Salem, and Portland, and St. Charles, and they all institute a similar policy. So we can't mandate that they get the flu shot, but we can mandate that they have to mask if they haven't gotten the flu shot.
Usually, somebody coming in the room is gonna have a mask on.
Yep.
Pink or green,
Yep,
okay.
How
Yeah.
about the board members?
you can come on by and get the flu shot anytime. And I try, like, I try, Jen tries to get all the information out to like our volunteers, auxiliary and stuff too, and we definitely would include board members, yes.
Out of curiosity, why do employees choose not to get the flu shot?
There's a variety of reasons. One is the multi-dose vial. A lot of them, dare I say, anti-government. I mean, they just don't want to be controlled. They don't want to have to say, I mean, there's probably 2 or 3 departments that I meet the most resistance from, and one of them is acute care. So most of them just think that they might get it anyways. And we did have one nurse who got the flu shot this year. She works the majority of her shifts in the ER. She did get the flu. But that's going to happen because the flu shot's only going to be about 75% effective. It's not going to cover everything. There are going to be those outliers. So I don't know. I think it will be a challenge. It'll be interesting, but I think it's for the best for not only our hospital but our community too, and our patients, to protect them as well as us.
Mesa, will we be able to have the inhalant?
So we won't know that yet until the end of this month. So that's another thing. So last year the CDC didn't recommend the nose spray, and St. Charles did say that on the years that that the CDC does recommend it, we should probably offer that too, because some people just have a fear of needles. I mean, 3 of my maintenance guys wouldn't get it because they have fear of needles. So.
I do too, but
Yeah.
I get my flu shot.
Exactly. So I mean, when I have them sign the declination form, I mean, there's tons of reasons, and I ask that they just mark one. I mean, so that I can kind of keep track, and it's all over the board why they don't want it. So.
Any other questions?
Let's get that percentage up.
Yeah.
Yeah. So
Thank you, Mesa.
I have one more.
Oh, one
So,
more.
so the other policy is about immunizations for our employees. So as I started doing this job in November and I started going around to different trainings and classes all over the state and region, it became very apparent and clear to me that we were kind of behind the times in keeping up with our employees' vaccinations, such as like the chicken pox, the MMR, things like that, especially in our newborn population, our employees that work for the newborn, like the ER, labor and delivery, the nursery, because those babies are at such high risk for any kind of disease, that I think it's important that we probably start screening our employees, and it's going to be kind of a tedious task because we'll have to do it in a breakdown of start with different departments. But St. Charles, upon hire, their employees can't even go to work until they've had all their titers drawn. So they draw a titer for Hep B, for MMR, for varicella, and make sure that they are immune. And if they aren't immune or they can't produce their immunization records, then they start with the vaccinations. And they have to have the vaccinations to be able to work with those populations. That, I think, is going to be a hurdle in a way that I've only had a few employees since starting this November that have any idea where the immunization records are. So we will probably just be drawing, if we can't produce those, we'll have to be drawing the titers, and it is a cost. So I mean, we'll have to do that. It's not a lot. It's less than $100 per employee to have all of those drawn, but it still is a cost.
You know how many employees we have?
Exactly.
But it isn't all employees.
No, it's not all of them. Most of the nursing and CNAs and stuff, they have to have that Hep B series before they can, even apply for their license and stuff like that or go to the school. So there's going to be a lot that we don't have to, and a lot of them that if they've had both of their MMRs or 3 of them, then they don't have to be drawn. I mean, there's a lot of exclusions included in the CDC Pink Book that we follow, and we don't have to draw those titers. But there will be some, especially those new employees that come to us, some people just have no idea what their immunization status is in the first place.
What are we going to do with travelers?
They will have to provide proof.
Is
But most of them do, sorry Judy, most of them, honestly, the traveling companies is probably one of the best. They honestly are. When I go back through, Holly and I have looked at some of them, they pretty much provide all of that. So I don't think they'll probably be too big of a problem.
Is there such a thing as a TB test anymore?
Yeah, it's funny you brought that up. So Charlie and Teresa and I've been doing a lot of this and working with it's called Quantiferin Gold is the blood draw now for TB. And like St. Charles, they don't even do the TB test, they just draw the blood. It started out $145, and Ginny and the lab and I were able to work with our rep and get it down to $65 per draw. We haven't instituted that yet. Right now I'm still doing the two-step. So that means anybody that comes in as a new employee or return employee and hasn't had a TB test, a negative TB test in the last year, I have to start over with the two-step. So it means I give, one TB test 1 week, and then at least, the next week or 2 or 3 weeks later. They have to have that completed by 6 weeks from the day of hire. So we're still doing that, but the Quantiferin Gold is a possibility that we could include onto our blood draw, so the employees would potentially only be getting stuck once instead of coming to see me for the TB test 2 more times, as well as getting their blood drawn. So that is a possibility too.
But that's mandatory, then they all have to do
Yep,
that.
they all do, and we only do it upon hire or, rehire, because we have such a low incidence here. The state doesn't require that we do any testing unless there's been an exposure or something like that.
The exposure can be because of some of the larger cities in the country where there's lots of immigrants that are people that are traveling. So in some cases, the exposure could be just simply going to New York City.
Yeah.
Because of the prevalence of communicable diseases, especially airborne diseases in large groups of people that have traveled from where it is more prevalent.
Mm-hmm.
We don't absolutely require that people have travel information.
Yeah.
And we don't have a lot of people in our community that are traveling to and from potentially hot spots in the country or around the planet. But technically, that's how it's supposed to be.
Yeah. So it'll be a slow but steady process once we finally get this in to effect and start working on how we're going to break down the departments. We'll probably start with like labor and delivery first, and nursery in the emergency room, and then we'll work that way over to the clinics and stuff like that, because they're seeing the newborns after they're born, and they're coming in for their well child checks. So it'll be a long, tedious process of trying to get everybody checked, but I do believe once we kind of get it into a system, it will just be like second nature, kind of like it is at St. Charles. I mean, it's done upon hire, and then we're done, and we don't have to worry about it. And I can also, I'm an approved super user on the Alert Oregon immunization site, so I can get on there and search too. When employees come in, if they don't have their immunization records, I can get on there and search. So if they have had their immunizations in the state of Oregon, then they should pull up, so we can look at them. Yeah. So that's all I've got. That's it.
Do you have a computer program that'll re-alert you every year?
No. So we are, Leslie and I, the HR department and IT have been looking at some programs that are electronic, like employee medical records, that would hopefully help both HR and myself, so that it would be easier to track stuff like this and a lot of other things. And that's kind of a work in progress, because it'll be a budget item that we'll have to approve, and hopefully find something that will work with our software as well.
Sounds like that could be very helpful though.
I think it would be, and that's what we're finding, that we think we've looked at 3 or 4 of them. So, yeah.
I mean, and really they're all very similar.
Yeah, they are.
It's price point that seems to be the difference. Yeah, so, and it's partly a challenge because we have to coordinate getting IT and HR and.
Yeah.
And,
We just, we probably need to meet
altogether.
again probably after Labor Day or something, once things maybe start slowing down a little bit, so we can kind of review them and kind of go over. But yeah, that is definitely something that we've thought about it, because right now, HR, anytime a new employee comes, or say it's an employee like we had one the other day, and she worked here 10 years ago, and she thought she needed all the immunizations and shots, and so Holly had to go to, what do they call it, the dog kennel?
Dog kennel.
Called the dog kennel, because they have to go back and they have to look through all the paper charts and files and try and find her last employment file. And lo and behold, she had everything. She didn't need anything, but she didn't remember that.
Wow.
So, yeah, it'd be great if we had a tracking system, yes.
Automation is wonderful.
Yeah. Can't be
When it
yes.
works.
Yes.
When it works.
Yeah. So that's it.
Okay. Thank you very much.
Yeah, thank you guys.
Appreciate it. Sounds like we got a lot of work. Excuse me. Financial report.
Okay. Okay. You okay?
Yeah,
excuse me for a minute.
Some water.
Go ahead, I'm gonna get some water.
So I spent several hours today, just so you know, looking through our financials for the year and comparing it to prior years. And I updated your closing June spreadsheet with several new charts and several new tabs on the spreadsheet, and I made them all blue where there's something new. And I'm gonna send it out to you tomorrow morning. I hope you look at it and let me know if you have any questions. I just took a really good look at, you know, what's the past years and what's going on this year and why, you know, really looking at our margin and our loss and why did that happen.
So that's closing out fiscal year.
Right, because, and of course, the auditors are coming and they're gonna look at some things and change some things. Certainly, I need to have discussions with them of what our expectations might be with CMS as far as our cost report and how we presented things and whether or not any of that's gonna change. And so my hope is that I have taken the most conservative route, so the only thing they'll do is add income. That would be, in my opinion, the best, you know, thing for me to do. So, and there are some, you know, a couple of good reasons why I think we might be able to improve our bottom line after CMS based on their advice on how we're gonna present our financials, where and how we record some things. Especially wellness expenses and whether or not we can go back and recoup some revenue from Gooseland. So anyway, patient counts for the month of May were 332. So it was a little bit less than May. Did I just say May? June, sorry, June, this is May. It's a little bit better. What I was focusing on today, of course, was year-over-year numbers, and this 39 patients and those 830 patients. And also, these numbers down here, you know, it's the decline in the number of patients we're seeing. I mean, those 40 patients represent 10% of our hospital business. And that ED number, 831, well, a lot of them did go down to the clinics, and that's good, but obviously what we charge in the clinic is a lot less than what we charge in the emergency room, and this is really what needs to happen. I mean, it's the right thing for the people. It's the right way to get treated, not in the ED unless you have to be. But still, those things really are having a significant impact on our bottom line. And the fact that there's a lot of pressure from CMS for people to get out of the hospital faster, or not to go at all. So these are big impact numbers, even though they don't seem maybe huge on here, especially that 39. Okay, so year over year, that's a total of 875 patients that we've seen a reduction in. Those have a big impact on our lab. The lab exams is down by 1,480, and I'm pretty sure that has nothing to do with our outpatient business, but has everything to do with our inpatient business. Radiology has stayed pretty steady, improving a little bit. Rehab is our big star for the year. That's a huge increase for them year over year. That's awesome. And the health clinic saw an increase as well. And of course, last year was really kind of this ramp up first year, basically. But still, those are good numbers, and it is intriguing that this number is so close to that.
Yeah.
Now, is there a reason the clinics wouldn't use the lab as much as the acute care?
The clinics use the lab a lot, and I don't think that their use of the lab has declined. I think that having 39 less patients who are having labs while they're in the hospital, I think that's probably what caused that. I don't really know. I mean, that would be an interesting thing to find out. I mean, how many labs does one inpatient generate? I don't know, probably might go find out, but. Okay, so moving on.
I was just going to say, sometimes acuity, types of patients that we're taking care of have different needs. And so when we have very small numbers. So when you have small numbers, acuity, or how sick the patients are, they may be in the hospital, but if they're not really sick, or they have different kinds of sicknesses, that can impact. Okay?
And we did have a few really slow months, and maybe we just had lower acuity. We had an odd year that way. Excuse me. Gross charges for the month of June were 2.9 million. They were 3 million last month, so those are very good numbers, and I hope that continues. Our monthly average is currently $2.6 million. Nice increase year over year for our gross charges. Our collections on AR was a little bit strangely low. I have not been able to discover a good reason of why that happened. Our collections were 1.67 million and our average is closer to 1.8 million. So based on excellent revenue in June, I'm a little baffled by that, but it could could be a day or two's difference between when the check got received and booked for us. But, I mean, I'm not terribly worried about it. I just wish it was higher. Our days in AR went up a day this month based on good sales and low collections. So, I hope we will see that turn around. The 217 number is this one right there. So, not bad, all in all. Our days cash on hand for this month was 103. Our average this year is 117, quite a drop from the prior years. The line I put there, remember, is the 90 days line, where we need to really want to be in order to satisfy our covenants with the bank. So I'd like to never see it go below that line. Again, I still am continuing to wait for the Lakeview Gardens project to be totally complete before I do the final borrow. It will be close to $1 million, which would bring our days in cash up to closer to 118. So I'm not sure still when that's going to be. But I think it's still worth waiting because it could save us several $1,000s. I mean, it would be silly in my mind to spend several $1,000s to borrow, what could end up being $50,000. So I'm still waiting. All right. Profit and loss for the month or in the year. Our net revenue was 2.4 million. We're 479,000 over budget. Our total expenses are $245,000 over budget. Continuing to see rising salaries, not a new story. Much of that is wellness centered. Benefits are pretty steady in where they expected to be. They are greater partially because health insurance went up and because we have more employees. This is a smaller variance than we've been seeing, so that's kind of nice. So our total expenses were $254,000 over budget, and our net gain for the month was $238,000. Which was $217,000 above budget. So our loss for the year as it stands right now is $240,000, which is kind of the opposite of what we planned on, so that's $480,000 below budget. And I guess this is, in looking at it very closely today, I was trying to look at different avenues for, what's going on with our margin. And if you look at the detailed P&L, which I did another abbreviated one that boils it down a little bit more, our margin for the hospital alone was $1 million below budget because we saw fewer patients and they stayed less time. I mean, and that's huge. I looked at the final impact of temp wages on the hospital itself. I think it was like, I don't remember the exact number, but $360,000 maybe over budget. Not spent, but over budget. So that $360,000 would have a big impact on that negative number right there. So those two things alone. I don't really see, it certainly wasn't the wellness center. They didn't have a negative impact. And the other thing I really looked at was contractuals. Our contractuals are where they should be, and they're not really going up. So that makes me happy because I don't want to see them go up, but it wasn't that. And I made a spreadsheet for that too, for work. a tab that you can see tomorrow, so please do look and ask questions. The balance sheet, oh no, sorry, this is the 5-year comparison that I just put together today. I've included that in the worksheet too. But you see good growth in income. You see big growth in salaries. And please remember, a lot of the jump from here to here was the clinics, the purchase of the clinics. And a big jump from here to here is the wellness center. So, amongst other things, I know. And really, here's our operating gain or loss. Really, it's not hugely worse than last year. And we did have less non-operating income. So, anyway, not bad, but really, considering the amount of things that we did this year, I think it's pretty good.
With that much expense in salaries, I still want to pursue the health insurance issue.
Oh, yeah, absolutely. I think that's a great idea. We spend so much money as a percent of wages. We spend a huge amount on benefits. It is big. Okay, for the balance sheet, which I noticed the spreadsheet we sent you did not have the updated balance sheet on it, so the new one does. Which apparently, Ron, you didn't notice that. I caught something.
Oh, good.
Anyway, really no changes. We neither paid out a lot to the construction company nor borrowed any, so month to month, very little change. And year over year, you see our cash is, year over year, looking at this and this, cash is up, assets are up, and debt is up, naturally, because that's all Lakeview Gardens building. Okay. So that is it for the hospital.
Okay.
What, oh yeah, well, I had those last month.
Was there nice pictures? Where did you get those?
I know, do you like them?
Any questions on the hospital?
Okay.
Okay, we'll move right along to the Goose Lake Medical. And
The pictures that Leslie took, she did a good job, okay?
Nice.
Lakeview Gardens had an excellent month. They had 720 patient days. That was the highest patient count all year long. So very good. Year over year, they had an increase of 635 patients.
Larry's been recruiting.
Been trying.
Maybe so.
It's not just me.
Dragging people in off the streets. Monthly revenue for the month was $211,000. That's well above our average for the year of $187,000. The profit and loss was impacted by our contracted labor was not as high, but unfortunately we had to pay. We had to hire a rather expensive consultant for the ALF, and that kind of hit us a little bit this month. So a net of, we had a loss of $16,000, but then when you add in the extra expenditures for our setup expenses, which are naturally winding down, we had a loss of $25,000. Year to date, a loss is $233. It would be $174 net of that. So interesting how things work here, awfully close to last year, not a significant difference.
What was your consultant for?
It's a requirement of the state to open up the assisted living.
Oh.
We had to have a consultant for 6 months, and there were some stipulations that, unbeknownst to us, we discovered we had to do.
And it is expensive, but I think she's already done us some good, for sure.
Oh,
Yeah.
I mean,
She's-
it's benefiting.
It is
us.
helping us,
So,
yeah. Balance sheet for Lakeview Gardens changed very little. Cash goes down because we pay back the debt. There's no reason for Lakeview Gardens to hold a bunch of cash, so whenever there's, extra, we send it back to Lake Health District and pay down this debt. So, no changes. Goose Lake Medical for June had sales of revenue of 48,000, which is pretty well below that 58,000 average. Dr. Faber is there working full-time. He's been there for almost 3 weeks now, I think. He seems to be well accepted and liked and is happy, so we are hoping that we will stay until we do find a permanent replacement. Goose Lake's balance or profit and loss statement, Goose Lake lost $4,000 in the month of June. That brings their year-to-date loss to $100,000. This thing is dying. $100,000, which is a little bit more than the prior year, but again, awfully close year over year. And their balance sheet did not change much. A little increase in AR and cash, but really nothing significant. And here's really happy news. Small as it is, this is our first profitable month for our DME business, Lake Health Medical Supply.
Hooray!
I know. So it's exciting. I'm afraid July won't be quite as maybe as good, but still definitely trending in the right direction. The oxygen patients continue to grow every month, and Michael continues to be very motivated and excited about this business, and really no change in the balance sheet. Questions? All right.
No questions? Moving on. Scholarship discussion. Leslie.
We received quite a nice little sum of money when I first started here, about $35,000, Charlie. So I was in the process of writing up the policy and the procedure for that, and there were a couple hiccups, so it's not done. So I'd like to forward that to next month's agenda.
Okay.
There's nothing to discuss. How's that?
Okay. We'll postpone this one to next board meeting. Okay, thank you. Then the next item is, of course, the Patricia Gamey Johnson Fund. We have 3 applicants.
Yes, I'd like to present all 3 applicants before asking for a motion. I think they're all quite qualified, and I think that you'll be very pleased with how their progress is going. And we have a new applicant, so with your permission, are you good with that? Presenting each one as a group, presenting all 3 as a group.
I have a question. And
Yes.
I have a question that needs to be handled in executive session.
Oh, okay.
It's not an open session issue.
All right. So should I go my
No,
presentation?
I would say present your information, we'll discuss it, and then we'll come
Vote
back
in
to
the
regular
executive
session.
Vote in executive and let me know. Okay. So we have Kylie Leach, who's our first applicant. And she is rolling into her 2nd year of the program and doing very well. And she received a 3.64 at Plymouth. And so she is requesting to continue to have grant funds her way. And so I wanted to present Kylie as a qualified applicant at this point.
Is she currently employed
She is, yes.
with the, I thought it said no on
What
that
does
one.
it say? Is she not working as a PRN?
No, I thought she is a prior.
No, she is not. She is going to school full-time. Yes, she is not working PRN anymore. She's lived, though, in Lakeview for a number of years and has a family. Her family is here with her husband. Okay, the second one is Kelly Utley. She is currently an LPN in long-term care and pursuing her RN, and she has been pursuing it on her own. And so she would like to apply for the Patricia Gamey Grant Fund to go on to get her RN. She's the second applicant. And the third applicant is Jolene Ray, and she's in long-term care as well, and she's rolling into her 2nd year. And she has so far a GPA of 3.76. So those are your 3 applicants for consideration.
I did have a question on her letter
Mm-hmm.
about travel costs, and that probably has nothing to do with her application for the Patricia Gamey Fund, does it not?
Right, that doesn't
Okay.
come under the qualifications of the scholarship. It is tuition, books, and labs.
Okay, has this letter been addressed internally? Is this something that, was it given to us just for information?
Yes.
Oh, okay.
This was just her, I'm not quite sure why she did a cover letter, but it just sort of came with the packet that she returned, so I thought I would forward it.
Well, this sounds like she needs money, this letter that I'm looking at. She needs travel money, or she cannot continue to stay in the program.
A place to stay over there.
Right.
That's
stay
the
in
housing
Klamath
one, the
Falls.
3,600
Yes,
or something?
that she had expected that she would be able to do some of her clinicals in Lakeview, and that's not happening.
Well, I think that I wish Teresa Squires was here because I don't know the inner workings of the program. Shirley, would you like to add to this?
It's all part of the conversation with KCC about having classes here.
Yeah, I would
So is
assume
it,
that.
is it possible that we'll be here?
Not only is it supposed to be possible, it's supposed to be happening. And so far, the indications we have is that it will. I can't give you exact specifics, but I know that a group is coming over next week to talk about it specifically. So I'll believe it when I see it. You know, sort of the Missouri attitude.
Well, my curiosity is that this letter is dated the 28th of July, and she's asking for rent and travel expenses, and is that happening? So you haven't,
Oh, no, I follow the policy. The reimbursement, the only reimbursement they did, and they have to turn in their expenses to me before I do a check request. And it is only for labs, books, and tuition. Because
Okay.
they want, they've asked me for a number of things, their scrubs, their stethoscope, and that's not part of the scholarship program. So we only reimburse what is in the guidelines.
so they will not be able to, this indicates that they would like to rent a house for the three of them, and so they don't have to drive back and forth from Lakeview to Klamath Falls, particularly in the wintertime, but all of that has been a no.
Right.
So, okay.
Yes. And I
That's why
don't,
we're working very diligently
Yeah.
to make a change.
Okay. Because I'm just curious if we will lose her in the program if she is unable to get some sort of financial help if she has to continue to go to Klamath Falls.
To tell you the truth, I didn't know about the letter. I have met with the students from KCC and talked about this very issue. So I'm certainly aware of it. And they're working very hard to get changes made at KCC.
We'll put this on the table and talk about it in executive session, and after we'll come out and make our recommendations. Okay?
thank you.
Thank you. Medical staff privileging, Mr. Gallagher is not here. I see that Mr. Hussey is on. I suppose we ought to approve that.
In the absence of Dr. Gallagher, I think you've got a list of the renewals and the new appointments. With the exception of Dr. Hussey, they're all radiologists. The medical staff has reviewed this and has recommended that you approve this. So on behalf of the medical staff, I'm asking that you approve it.
So moved.
Second.
It's been moved and seconded to approve the medical staff privileging as presented. All in favor?
Aye.
Opposed? Hearing none. Motion is approved.
Thank you. Can I have the mouse? please?
Board education, and maybe board retreat.
Maybe we could talk about, there's a,
Down at the very bottom. No, I'm sorry, in the USB drive, you go to, okay, that one works,
which one?
right there, it's right there. I drug it into mine as well.
Let's see. So, I hope this works right. If it doesn't, I'll send it out to you, and y'all will feel educated. So, one of the things that I have been working on, through a grant that the Hospital Association got, we do have a program called Govern Well. And it's a very comprehensive board education board with a series of issues. I think I told the board last month, that the findings are that boards across the country are not all operating at 100%, like you most often are. So American Hospital Association is working very hard to make a change on that. What am I doing? Sorry. So a lot of it right now, as I look through it, it is a vast amount of information. Sorry. Thank you. How do I exit that?
There we go.
Sorry. Sorry, I don't want to touch it.
Would you like to sign up for some training?
Yes, please. You know, it never ceases to amaze me that when you think you know something and you get in front of a crowd, you never know it. It's the nature of how things work. Anyhow, so I'm not really prepared to give you, because so much of what you're already very good at operating as a board. So some of it is pedantic and not something that you need to be looking at. So when I look for things that would be of value for us to talk about, some of it, frankly, is what we do when we go on our retreats or our planning session. And Don and I were talking about how it might be appropriate in the very near future to have another half-day session to talk about a lot of the issues, because there is so much that's going on. I don't know if I did. When we had our annual CEO meeting 2 weeks ago, and it was a Wednesday, Thursday, Friday in Central Oregon, and that was, the Monday was when the Senate agreed not to move forward on the ACA repeal. Tuesday was when it voted not to even talk about throwing it out. We started Wednesday. We had a presentation from Merkley, Senator Merkley, which was a videotape, but he probably made it either Wednesday or I think it was Wednesday, talking about his anxiety about this. Friday we had a speaker from, his name is Charlie Cook. You may have seen the Cook political report. Very, very knowledgeable expert on the politics in Washington, plus the politics in Oregon. And then we were, our guest speaker was former Governor Kitson. So it was a series of very big political discussions, because there is so much going on, as I'm not telling you. So what I thought I would do is show you, this is a report we got just recently, talking about our CCO business. This is the Medicaid business, the expansion population that we're taking care of. And what this does is looks at how our numbers, can you hold down the control button? Thanks. We represent, of the total Eastern Oregon CCO, about 3% of the business. The vast majority of the business is in Pendleton, Hermiston, LeGrand, and or Grand Rod, and Baker City, so that swath of the state. But of our population, we're segregated into two portions of Lake County, North Lake and South Lake. I only chose to show you South Lake because we have more impact on that. North Lake, that business is managed, those patients are cared for by Lapine Clinic through the North Lake Health District. So what we look at when you think about this is for the period, the membership in 2017. We had a total of 1,051 assigned members. Of that, it's not quite 50-50, but close. And this is the age groups of the people within this population, okay? And so you can see that we have, of all the membership, we have a very similar populations, so our sex mix and age mix, in comparison to the other portions of the whole population of CCO membership, were very similar. We don't have anybody much older, we don't have a lot of people that are much younger. We're very similar, okay? Where'd it go? Too fast. So that's just a graphic of that, as you can see. Now, what this shows is the breakout by month and the kinds of changes. Typically, when this doesn't show this, historically in the Medicaid population, you have a churn of about 10% per year. Now, what does that mean? That means that people are, because of loss of job, change of status, they may have a variety of changes in life, they may have a child, and so they go into Medicaid and then they go out of Medicaid. So they also move, so about 10% of the total number changes during the year. You don't see that reflected in these numbers. The numbers are pretty stable. As you can see, in this population, it was virtually no change. In the 6 to 18 age, some nominal changes. And some of that is because if a parent gets a job someplace else, they move from the area and they take 5 kids with them, or 3 kids. That's the kind of change that you're going to see. The expansion population that all of the discussion, or not all, but much of the discussion was about in Washington was this component, the ACA. And so it represents 40% of the population, 33% of the total CCO population. So that's the 75,000 total membership within the CCO, not the 1,000 that we have. Just gives you some idea of the kind of mix and the changes. I don't want to belabor it, but I just thought you find it interesting. This is an interesting way of looking at how do people use healthcare. So on the left-hand side, we had 33, almost 34% of our total population of 1,584 people that did not use any health services during the year. And the period is from March 2016 to February 28, 2017. That's very similar to the total CCO population. So what we want to look for is, do we have outliers? Frequently in a smaller population, you have greater outliers. So you could have a couple people that really run up the tab. They're really sick, or they say somebody has a high-risk pregnancy. That could skyrocket the costs. So a high-risk pregnancy would be somebody with an expense of $150,000 or more. We didn't have any in this time period. We had a lot of people that had costs, as you can see, in the 10 to 50,000 range. That's where much of our costs occurred, although it was only a little more than 5% of the population. So one of the things that we think about as health policy focused individuals, we want to look at the 5% that are causing the vast majority of our costs, maybe 8%, and target what can we do to help them? Some of it, there's nothing you can do about it. Some people, maybe we can make a change because they have the greatest impact, those individuals within that age, this is not an age cohort, within that amount that they're spending. How do we try to make a difference? If we can save ourselves money, okay? So that's the nature of trying to manage a population by focusing on not the people that don't need care, the people that have really high expense costs. It could be an accident, it could be a very unique experience. The vast majority that we want to focus on is in the areas where we could make a difference. Okay? We have larger numbers of people that have, as you can see, 28% of our of this population had less than $500 in expenses, but it amounted to a very small percentage of the total cost. Questions, thoughts?
And those numbers are, we give, the numbers come directly from us?
The way they come is by the bills we submit.
Okay.
So you may recall I talked about how NOM had been working on a project in the clinic with the clinic staff, with Juanita, to try and make sure that, number one, we meet some criteria that come up in the next report. Not quite. It isn't in that. From the clinic, it's in sort of this area. So if, what we have been working on is, if we chart it in the medical record, the medical assistant or the doctor says, I did this. But if we don't bill, the bill doesn't match the record. We're either not getting credit or we're not billing correctly. So we work very hard to make sure that what we say in the chart is what we say is in the bill. And often, we say in the chart we do much more than what we actually bill for. So making those balance is a big part of this. Yes, sir?
In that population group that's your big cost, can you focus on the diagnosis?
Absolutely. I'm not showing you that, because then we start getting into, we have much more information on this. And so we're drilling down, looking at those individuals, well, looking at the diagnosis and what the kinds of issues that we can focus on. And then we drill down and look at the individuals. So that's very targeted looking. What can we do to help provide them the tools to reduce the probability of those expenses? Okay? So,
Charlie, just one other
Yes, ma'am.
curiosity. This includes all clinics, all of the clinics, or is this just hospital-owned clinic?
okay,
Does
this is
this
all.
include Warner Mountain?
Yes, it does.
Okay.
This is the total population.
Total, okay.
So it's not segregating out.
Okay.
Okay? So, because from the CCO standpoint, it's the total population.
Okay.
All the bills that come from it. Did you have something you wanted?
Me?
Oh, okay. I thought you were waiting.
No. Oh, no.
But again, our examples are very similar percentage-wise. And that's the thing we want to make sure that we're not experiencing a population that is higher at risk than the norm. If that were the case, then we would go to the CCO and say, you need to pay us more because we are at higher risk. And it doesn't appear to be that's the case. This looks at it a little bit from a different standpoint, shows you dollar by age of the population. So from the 5 to 14, you can see 45,000. We spent a lot of money on, and that could be because of kids getting accidents and going to the emergency room. Or other kinds of stuff that can happen. Our 75 plus population, we don't have a lot of expenses. As a percentage, it's very, very small numbers you can see here. The vast majority of our costs are in the 45 to 64%. And frankly, that's a big part of the expansion population.
Why are the people over 65 not Medicare?
Because there's those individuals that are a combination Medicare and Medicaid. And so that's where you get that portion of the population. Okay? Another way of looking at how the dollars are spent. Very graphically, you can see that that's our population age-wise that uses most of the expenses. Historically, in the Medicaid population, it was designed to be a service for moms and kids. And so you saw the vast majority of the expense in children and then moms. Historically. That's why this is the Affordable Care Act expansion portion of the population. When you look at how our expenses occurred, now the term per member per month, What that means is you take our 1,500 members assigned to us per month times 12 and divide the total cost, $3,500,000, by that number, and you come up with this number, $261. That's what our cost is per member per month, on average, okay? And so what we wanted to look at through this process is, what are the areas that we are spending more money? Clearly, maternity is dollar-wise is a bigger amount. You can see the percentages here. So pathology, lab, and radiology is a big component. It's a diagnostic tool. So that's why we have it. When you look at our percentages, we're a little higher in our diagnostic services than the rest of the CCO population. But we are also lower on the inpatient. We're half of what the other CCO component is doing. We look at our outpatient, we're about the same. We look at our emergency, it's a little higher, but not significant. We look at our radiology and pathology, we're right on line. Our primary care is a little higher. What that means is we're delivering more primary care than on average is being done, not significantly, in the other parts of the CCO. We are significantly less in our durable medical equipment than other parts of the state. And our prescription drugs are lower than the other component of the CCO. Okay? This is cost by gender and age. This is where the preponderance of the inpatient services are taking place. As you can see, 50% of the admissions occurred in Lake District Hospital. St. Charles Bend is the second. Skylakes is behind that in the sun. It gives you a graphic of where our business is going. This is a killer for everybody. This is the cost of pharmaceuticals, how we're spending. The CCO is working very hard to try and figure ways to manage the dollars better, to find better ways of buying. I think the part that is hard for everyone to deal with is, where's the opioids? The anti-diabetics is a very high number, but the opiates here.
Right on top is opioid.
Right on top. So that's how, when we look at how we're spending the healthcare dollars in our community versus the whole CCO. This is not the whole state, just our CCO. Some things were very, very similar on, some things were a little higher. But that's our population within the Medicaid population. And then this is by classes of drugs. Again, you can see the highest prescription amount right here. But we're not an outlier. In fact, we're a little bit less than the other counties within the state, or within the CCO. This is the kind of information that we provide to our Community Advisory Council, and then we talk about what can we do with some of the dollars that we get to try and help programs within Lake County that we can do to alter some of these. Some of them we have very little impact on that we can have. Others. Any questions or do you find this of interest, of value?
Very interesting.
Okay. I just thought you would find a little bit more about what we think about when we think about population health. Because what we're really doing with this is now getting to the world of health analytics, healthcare analytics, is starting to take this kind of data, claims data, and trying to develop programs to address health issues in the population. Some of it is the people that are coming to get care. Some of it is people that don't come in. They're the waiting time bombs. We don't know what they're going to do. How do we find out what's going on with them, because they could pop in and they're really sick. We're not necessarily addressing it. They could be perfectly healthy and not have a problem. On the other hand, so that's the, as we analyze our data and think about what do we do to make it better. Any other thoughts or questions? So what do I get?
I'd like to just insert real quick, you mentioned board retreat.
Yes.
I'd like to discuss that a little bit, and maybe set a time that we should set aside for half a day next month or so.
After Roundup.
I thought maybe the day before Roundup.
Thinking about the rewrite room?
Yeah, the Are there any suggestions? I'm thinking probably the latter part of September.
That probably works best.
Probably have a bowling alley.
Have the bowling alley. We could inaugurate the bowling alley.
Yeah.
Take pictures.
Are you on track for time? Chuck, are you gonna be done by 1st of October?
I'm not gonna answer that question.
It's kind of like the move-in date for,
Yeah.
Have you tried to get
doesn't it?
yeah.
You try to get a carpenter in this town?
Oh, I suspect.
Do you want me to send an email out to see which days are good for you guys then?
Yes, that would
Of
be an
that
excellent,
latter
excellent
part.
suggestion, then we can.
Okay.
Okay. With that, employee recognition.
Always great, fun to think about all the people in it. We have so many great employees and people that make such a difference. This is a person that, whenever people come here, they often, this is one of the first places that they stop in. It brightens a lot of people's day. It's Joe Caffrey, our coffee shop.
Oh, nice.
She is a great barista. She is a wonderful person to greet people, and it's astounding. You know, we thought, remember when you first got here, and I don't know, this is not going to work. We far exceeded the number of drinks that we ever anticipated, and it doesn't change. So, and much of it is because of Joe.
And our obesity is increasing.
Our staff is wide awake.
There you go.
They're skipping down the halls.
That's, I won't go there.
Excellent, well, thank you. Okay, CEO report.
A lot of things going on. First off, Larry, do you want to talk about the move-in issues?
Sure. We finally got approved today from the state to move in. So we are moving on Sunday morning.
Oh, you're moving patients on Sunday?
Yes,
Residents.
Whoa.
residents, yes. So we're going to start around 8:30. Our management team is going to meet. I'll probably get here around 7, and then we're going to huddle at 7:30, and then start moving people right after breakfast. So
Can
it's
you
the
do
last
it all
bit.
in one day?
Absolutely. We plan on being done by noon at the latest.
Oh,
Really?
wow.
We, throughout the last couple weeks, we had anticipated on moving in last week. Things like that it really helped us pack up the residents' belongings and move them already to the current room or the new room that they're going to be in. So we have 90% of all their belongings already packed up and moved,
Oh,
ready
wow.
to go over in the new homes.
So
So
many residents?
24.
24.
So long-term care is filling up.
Yes, it is
12
at
and 12.
capacity.
Did they get to choose their rooms?
For the most part, yes.
Did they?
So when we kind of decided some residents needed to be closer to the nursing office, so then we could have a closer eye on them because they're a little bit higher risk for falls and things of that nature. So we kind of gave them the chance to pick their room within a certain limit of rooms. A lot of people wanted the rooms looking out the back, so
At your house, Gerald.
yeah, to have that
Come
view.
on.
So
But
Larry, was there any designated separation of who moved where? I mean, is everyone mixed just random 12 and 12, not level of care or anything?
We split each house, so then there's a real similar level of care. So then one house wouldn't have all the higher level of care residents. We felt that if we had that, it would be hard to retain our staff in that home. They'd want to come over to the other home. Because I worked in a facility that had 2 different levels of memory care. One was low level and then the other one was high level. And it was very hard to maintain those employees in that house. So we talked with our team and we decided to split it as evenly as possible.
How about the assisted living?
That we actually we had to create around 200 pages of documents to send into the state, which was one of the things that the consultant helped us with to create. I sent that into Warren Bird, I believe. He's the policy analyst at the state that's reviewing our policies yesterday for review, and he is actively reviewing those as we speak.
We probably will not be able to open until he's done his site visit, but they're talking about a site visit this month. So
Oh,
it's frustrating that it's taking as long as it has, but
do we have quite a waiting list for that, or quite a list for assisted living?
We do. It is, off the top of my head, we have 25 plus people.
Oh, wow.
What really helps is our consultant works directly with Warren Bird at the Oregon Healthcare Association in teaching the assisted living administrator course. So we're hoping she can nudge him along to get those reviewed sooner than.
So how are we selecting 12 of 25 applicants? Is it first come, first served?
We're going first come, first serve, and we also have to think about levels of care also. Since we have 4 levels of care in our service plan, if the first 12 are, let's say they're all 4, or they're all 12 level 4 cares, that's going to be quite the burden for our care staff. So we're going to try and balance that out as much as possible to begin with, and kind of go from there. We want to do as much as the first come, first serve basis as possible.
So you haven't taken any long-term care patients into that program?
Not yet.
Are you planning on that?
Yes, we have quite a few, well, not quite a few, 2 to 3 right now off the top of my head that would qualify. We have to do the service plan to see which level they are, but they ultimately will get the first.
So that could free up 2 or 3 long-term care beds?
Absolutely.
I see.
But at the rate we're going, I don't see us having those beds open for long when we move those through. Because we have 3 people right now needing care right now in our long-term care.
Wow.
So when we put everybody, it sounds like we're going to have both facilities filled
All 3 buildings
in
should
a
be
fairly
full.
short period of time.
Okay.
And our long-term care right now is 24 people, so we're going to be adding assisted living into the budget.
it has been that.
Has been added, okay.
It's late.
It is.
We already need that 4th one, don't we?
Provided that the waiting list stays strong.
Yeah.
But remember, when we looked at what the study showed, is that it could justify it, we just had a hard time believing it. And so we wanted to be more conservative. So that's,
I'm actually quite surprised that there are that many assisted living. I thought we would fill the house, but I'm really quite surprised that there are 25 on the list.
I think the newness will wear off after a while, and that'll balance out a little lower.
Did they come from like Paisley and Bly or any of the outer line?
We do have quite, I'm going to say maybe half a dozen from Bend and Klamath
Oh,
that
really?
were Lakeview residents.
Oh.
And they had to go outside of town to get assisted living services and they want to move back.
Sure.
So that's kind of the majority of the people who want to come from out of town, basically back home.
That would be interesting.
We also have a CNA class going right now. Jade was We're lucky to have Jade on the scholarship committee. We offered 4 scholarships to this class. We have high hopes for this class because 3 have been CNAs before or have taken the CNA class before. So they know exactly what to expect. They just let their licenses lapse for personal reasons. So now they're wanting to get back into it, and we're happy to provide that for them. So
That's awesome.
Good.
What about
That could have a
staffing and
huge
business?
impact on our staff issues, so we're very hopeful about that.
Well, that sounds really positive compared to the one I said.
yes. Yes, we
I'm
were-
sorry,
all
Jane,
three of us.
that was the most unique session we had.
Who was it?
Yes,
Well, that's good news.
yes, you sat in a very interesting, yes, that was unusual.
And we have one current employee from laundry that is taking the class. So that's exciting.
Great.
Thank you. We, based on our board meeting, the last board meeting, you authorized me to sign a contract with Lake Health Clinic expansion, and we have been meeting on that. The contract has been signed, and it appears that if we get the permission tomorrow, which we believe we will, we'll have the notice to proceed on Monday. So they'll start moving dirt around pretty quickly.
Who do we get permission from?
We have to have building permissions, we have to have the
Permits?
permits, rather,
Okay.
the ecological approvals and all the other things. So there's a fair amount that we can start on before we have that, but we're moving forward. They'll move their site truck, for example, and all that kind of, not site truck, the trailer. So that's moving forward. One of the things we're required by the state to report on, so I'm telling you, we did not have any data breaches in our 2016 and 17 year so far. So we have had 2 HIPAA breaches where individuals were looking at or accessing information that they should not have. We have counseled them and have taken corrective action to address them. So we are also looking at, we're investigating some software that, similar to what other bigger hospitals have done, is to help identify HIPAA violations. With an electronic record, it's easier for people to look at charts that they might not have looked at on paper. So it becomes a bigger issue when you have VIP. So somebody was a big deal in the community, people want to go and look at what's going on. The same problem occurs when people look at family members that they shouldn't, or neighbors, or that kind of thing. Because of access, we have the software, but it's hard to track and look for if it's just a one look or a one something else. So we're looking at that. We also are evaluating insurance to protect against cyber threats. That has become a bigger and bigger issue, as I'm sure you've read about. And we've talked about it. But we have been, a year ago, we hired a consulting firm to help us on a month-to-month basis target areas where we might have problems and help do studies to test if we have vulnerabilities, and that has really made a difference. So we haven't had any breaches in this last 18 months, largely because we also bought some very aggressive software to stop any malware or ransomware. So I want you to know about that. The KCC agreement, I have not finalized yet. They did make some modifications to, and Dave and Christy and I are, she's coming up to speed on it, but we've got some language that says substantive contribution. We would have substantive contribution to the evaluation of the KCC staff. So that gives us more that language specifically, more than just we get to sit on an advisory committee and sort of make suggestions. We did, and we didn't get a lot of, listen to us. We've also asked for meaningful input into the program administration, which talks specifically about having students and having classrooms synchronously taught here to work on that issue with the kids. It's not completed, but that's the kind of language we're working on getting. So I will continue to press forward on that.
Charlie, has Teresa been involved in that?
Absolutely. In fact, Teresa was invited the first time to go and interview the candidates for the next cohort class, where we had several students from Lake County were involved in the interview process, or were being interviewed, and the others from wherever they were collected. So that's a big step forward. So it's not completed, but we're working. We had 2 surveys in this last. We get surveyed by the state frequently. Pharmacy was these are walk-in surveys. The pharmacy was surveyed and we passed without any problems. We were resurveyed in long-term care from a previous survey, found to be no problems. So that's always nice to have. Sometimes, we were also surveyed by Gobi in our mental health. I don't know if I told you this. The survey was in March. We got the report at the end of July. We responded. By and large, they found that the only issues that we needed to do is to step up our evaluation of how our staff members chart. Well, we've been doing that, but here's some extra things that we're doing. So surveys are good. They find areas where we can get better. We haven't found anything that says, nope, we've got a real problem and we're not going to continue. So that's positive. Our JPIA meeting, the next one is scheduled for April 16 in Modoc. Pardon? What did I say, April?
Yeah.
I moved months around a lot. I'm just checking to see if everybody's awake, that's all. August. I know it's August. And a big part of what we'll be talking about, really 2 things, is the information that I gave you back in February when we got it, about where our patients are going. And then the next is what kinds of things we can do to work on them together. Just thought you might like to know, the Oregon Hospital Association has a business called Apprise Health to manage the Medicaid business, the Medicaid patient billing business. They're the same group that will handle the tax that we will be taxed on. They take that data and then process it. They gave me a report 2 weeks ago that absolutely corroborated everything that our Hall report. It was a little more current. It was from 2016. And it said the percentage of business matches what the Copper Hall did. So we're staying consistent. And that's good. Judy, if you're able to go to that meeting now.
I'm planning on it, Charlie.
Right.
Did the meeting start at, it looked like it started at 1, so is there no lunch?
I'll find out. I expect, if there isn't, we can grab something. If not, I thought they were going to provide.
Well, she did say 1 to 3 and 4 o'clock at lunch,
Right.
so.
Okay.
You're looking for a free lunch?
Yes.
Girls gotta eat.
We have a couple events coming up in the next 2 weeks that all of you are invited to. The employee board and volunteer annual picnic at the park next to the swimming pool. So all of you that want to stand up in your Speedos, do come if you want to. If not, from 1 to 4, we would love to have you come.
What day is it?
It is Sunday, the 13th, from, 12 to 4. The kids will probably wear their Speedos. I think all the adults will be. Just saying.
No,
Underestimate us.
Bring your swimming shorts, Chuck. It'll be open.
I'll agree.
I have a,
Sorry, Dawn.
we have a sign-up sheet in admin so they can get a good count for what to give numbers to
So
Happy Horse. So if you want to let me know if you're coming and bringing anybody with you, I can.
You're not gonna have the barbecue.
we are, Happy Horses going to cater. The other thing that will be happening is our triathlon, the annual home health hospice triathlon will be on August 19th. So kids and adults that,
I'm not.
okay.
I have a placeholder for you.
We've had a couple, we're really blessed to have many people that have worked here for a long time. We are honored so often. Donna Morrow had her, I believe it was 30th anniversary here. But Barb Davis is retiring at the end of September. She's been here 45 years.
Wow.
So she's been a loyal supporter of the district, and appreciate and hope she enjoys her well-deserved retirement. There was a report that just came out from the state, the Oregon Health Authority, that evaluated those hospitals. There are 26 in the state that qualify as small or rural, and determine if they're able to keep their cost-based status for the Medicaid population. Once again, we continue to keep our cost-based status. Two reasons. One, because there is a metrics and we meet that. And number two, because we are a frontier county. So all frontier county critical access hospitals, no matter what the score is, get to keep their cost-based reimbursement status. It's sort of embarrassing sometimes when I have to tell you things like this. When we worked on the orthopedic expansion, we believed we needed to have an extra sterilizer. And as part of that extra sterilizer, we needed to have a special sterilizer heater pump above the building to provide additional steam. We were disappointed to learn that. The company came out and said, "Oh, no, you don't." Then they said, "Yes, you do." Then they said, "Yes, you do." So at the last board meeting, I said, "Yes, we absolutely have to spend this $16,000. I'm here to tell you the good news is we don't have to do it.
We generate
I can't
enough hot air
believe,
here.
I beg your pardon?
We generate enough hot air.
Absolutely. And so,
It all changed after you went up as chairman.
so sometimes you think you have good advice, and it never ceases to amaze me how it doesn't always work out.
But lucky for us, we found it out before we had to spend the money.
Yeah.
Well, actually, we had placed the order, and we called up and talked to the company and said, "This is unbelievably ridiculous." And he agreed and canceled it and didn't charge us.
Okay.
So it was, but I wanted you to do this. We also bought our new transportation van, so you may see the white van, because we need to be able to, as we haul things between the gardens and here, as well as to the other sites that we're going to. So that concludes my comments, unless anyone has questions. That's something
I have one thing. I'll be sending out the agenda and information tomorrow on Dr. Jarrett and her visit next week. So I've been firming that up the last few days, so.
Okay, with that, we'll go into executive session under 192-660, record 2, record A, personnel and the medical staff, record C, H, legal, and J, property. And we'll have our attorney stay. Do we need anybody else to stay?
You know,
Charlie?
it might not hurt if Leslie stayed. for my
Okay,
question.
okay,
that I
for the
have.
first part, we'll
For-
have Leslie stay and then we'll chase her out later.
I have some additional information shared from Larry too.
Okay, 10 minutes at 8 o'clock, we'll